going to invite Dr. Pooja Khamar, who's come out from Rangachari Award judging, I think, to give this talk. Thank you so much. And she's talking on something which they have done tremendous amount of work at. She's been pioneering lots of new techniques on PRK at Narayan Nethralaya. So please, we'll be happy to hear you.
Thank you,
And
sir.
we got the hall 5 minutes late, so we'll try to finish it off as fast as we can.
Thank you, and I'm extremely grateful to you for making me a part of this IC. I think I'll stick to the important slides which have not been covered. So we all know by now that PRK is a procedure of choice when you are dealing with a thin or extremely steep or a flat cornea, or your corneal thickness is a borderline between 475 to 500 microns, or sometimes if your RSBs are going below 300, I think and your refractive error is less than 6 diopters, or if the patients are into contact sports or into armed forces, or any of such procedures where they can get hurt or trekking, one of the procedures to go for is the PRK procedures. Now, PRK has transitioned a lot over time. It started with a manual removal of epithelium, then it went to PTK along with PRK, which is so-called trans-PRK, a two-step trans-PRK, then came the one-step trans-PRK, and now we have all different technologies which offer you a one-step trans-PRK. So now what is the difference between LASIK and PRK? Grossly, if you see, is one of the advantages in PRK, you do not have any flap-related complications. We do have CLEX, but it also has its different learning curves. But PRK, there are no flap-related complications, or it's more suitable for patients with thin corneas and an active lifestyle. And the most important part is the corneal nerve preservation in PRK procedure is much better than that of LASIK or SMILE. So I think that is one of the reasons, when patients have ocular surface diseases or if they have dry eyes, trans-PRK could be looked at one of the factors. Now, I'm going to be talking from Schwinn perspective, but what I'm going to highlight here is very important. Now, when you are doing a trans-PRK is nothing but the laser removes your epithelium followed by power correction. Epithelial map is one of the very, very, very important factors, because if you're doing laser is going to remove the epithelium, you can't just go ahead and enter 55, because your patients might have a center of 55 and a periphery of 60, or they have a epithelial thickness of 65. And these are the patients who can land up into an overcorrection or an undercorrection, and you probably might not know what it is. So if you're doing a trans-PRK, always try to look at epithelial map. And if you have an irregular epithelium to begin with, of course, treat the ocular surface, but go ahead with a trans-PRK, because the post-op remodeling of epithelium in this trans-PRK is much better. You can use drugs like cyclosporins and sodium hyaluronate. That will give you a good epithelial remodeling, which will give a good quantity and quality of vision. And if you see different technologies which gives you trans-PRK, I think there is not much of a difference, except there is a faster wound epithelial healing in SmartSight, which is from Schwinn compared to that of Streamlight. But otherwise, there is not much of a difference. Now, the second choice of procedure, why I like PRK, is if you see, this is relatively a healthy looking topography and a thickness of 563. So anybody would be tempted to go ahead and do a refract like a LASIK or a SMILE for these patients. But if you look at the epithelial map again for this patient has a donut shape of an epithelium. That is nothing but an early sign of evolving ectasia. And Professor Dan Reinstein has done extensive work on O sign of or a donut sign of epithelium. So we do know that even if today the patient doesn't have ectasia, probably tomorrow he or she may develop. So always, to be on the safer side, you can choose a trans-PRK procedure for this patient. PRK again is, a lot of times patients have come back with regression post-LASIK done elsewhere. You do not know. ASOCTs are not able to pick up if the flap is even or uneven. Then again, if it's a very thin flap, there is always a risk of lifting up the flap because it can lead to a flap tear. So PRK after LASIK also can be done, and it's a very good procedure because it is a procedure which will lead to lesser dry eye, no risk of epithelial ingrowth, no destabilization or weakening of the cornea, and you can use mitomycin C as ma'am suggested. You can also use PRK after PKP or RK, which has been done for a recorrection, because that is the procedure of choice which you would want for this patient. And PRK can also be done for patients after cataract surgery if you have a refractive surprise. Now, a lot of patients do say that, if I do a PRK, the quality of vision is not very good. The answer is not that. If you have taken care of your ocular surface very well, and if your machine is well calibrated, there is a very, very, very minimal risk of refractive surprise post-surgery, and the quality of vision maintained is also very good compared to that of LASIK and SMILE, and this has been published in JRS. And the risk of haze, people say yes, we are scared of developing haze. So this is a very nice algorithm which talks about if you are doing a trans PRK, what all signs you should look at, which will predict that whether your patient is going to develop haze or not. And if you think the patient is going to develop haze, you can pre-treat the patient. And after surgery also you can use sodium hyaluronate and cyclosporine based drops for reducing haze. And regarding the pain, which is the other demon, you can use a cold chilled BSS to wash your ocular surface after the PRK procedure, and also use a cold BCL and which reduces the pain much effectively. So if you see PRK, yes, is an advanced surface ablation procedure, and it is, I think it would be a go-to procedure because as Chitra ma'am mentioned, it induces lesser biomechanical changes in the cornea. It is also go-to procedure for post-recorrection patients. If you have epithelial abnormalities, you know that you want to treat the patient with a trans PRK, and also PRK is associated with very, very, very minimal risk of ectasias post-refractive surgery. So I think that would be my go-to procedure compared to others if I have an option for it. Thank you.
Thank you, Pooja. That was wonderful. And you know, Kamal is sitting next to me and he's been prompting me again and again and saying that अगर हेज का डर निकल जाए तो मैं सारे पीआरके ही करा करूँ.
सर साइक्लोस्पोरिन यूज करना शुरू कर दो.
Right. So I was going to ask
सब
you.
यूज किया है, but जब आनी है ना तो आनी है.
वो तो आनी है सर, बट वो तो स्माइल में भी एक्टेजिया होना है, रिग्रेशन होना है, and so I think every procedure has its disadvantages.
So I wanted to ask you, what percentage of patients in your practice, like you are doing large numbers of PRKs, right? What percentage of patients eventually go on to get haze after all that we do, like all the measures that we make? Suppose you are doing like 1,000 or 2,000 procedures per annum. How many do you think? Because haze will present within the first 6 months to a year most often if it has to.
I think the incidence of haze in our practice with doing all this, there is an incidence, as sir said, you can't say that it's not there, but it would be probably 1 in 500 patients, so which is extremely low.
Exactly.
And if you keep your patients on follow-up, and I have had patients who have come back with haze at 1 month or 3 months. We start them on tacrolimus right away. So it significantly reduces. And the second most important thing which works very well is vitamin D. So initially I never used to believe in vitamin D treating haze, but I think these two factors have helped a lot. So
absolutely. So I think I was telling him the same things, and incidence is actually very low. It's not very significant. And Kamal, you have to go learn from Pooja how to
no,
do
I
PRKs.
have to complete.
And
Biggest concern is that I've been burnt very badly. There was a young girl going for, I was sharing the stories, 2 or 3 stories, and it was so devastating for me as a surgeon. She went into depression. She couldn't clear a medical for the job she was going in for, and there was nothing I could do for her because everything I followed, and still it happened.
So that is one of the reasons, again, that is a genetic factor which you cannot factor. So above everything, we do have to remember that there is going to be a genetic factor which even if you do recorrection, they may develop.
even Dr. Chitra Center does high volume PRK, I know that. So what's your take on haze, ma'am? Quickly, if you can tell us.
But everybody needs to believe me that we just not had haze. Those patients, one odd patient who has had haze came after a long time. They had stopped steroid drops. We put them on topical steroid drops in a tapering regime for 3 months. We keep them on vitamin C also and artificial tears for a long duration. And we use mitomycin on the surgical table. So this is all that we do. And it's transepithelial PRK. We don't do mechanical debridement or alcohol. So otherwise, we have not. But then, we don't ever do more than -6. So that is one thing which is limiting, which is also one reason. Only in higher paths you get haze. So then you should use exposure for every 1 diopter, 10 seconds of mitomycin has to be
LBP
used.
protocol is 1
LBP
diopter for every diopter, 10
I
seconds.
just have one point to add,
Yeah.
if I may. So again, trans PRK is a very good procedure, but it is not always like, because now we have LASIK, SMILE, ICLs, it's not the first line of management.
Yes.
But wherever you do not have an option,
Then.
trans PRK
Yes.
works very well.
Yes.
Because you know it's not right to reject a patient for wrong
Yes,
reasons.
yes,
So I think it's always a backup option.
Backup option.
Okay,
yes.
final question because this course, yes,
So do we ask our patients for UV protection?
That
yes,
is the
coolers.
key. That is the most important thing. In
100%
fact,
cooling
on,
glasses.
on every visit, I reinforce UV protection to them
Yes.
because that's again very very important.
Very
I had a guy whom I did like the highest I do is 100 microns of central ablation and with a good amount of mitomycin, like 30 seconds is what I use
Yeah.
for those high ablations. He went skiing 1 year after. I mean that was a -7 or something I treated, -8. Good counseling, 1 year doing extremely well, went skiing for a month in Europe. After a year of surgery, came back with severe haze.
Yeah.
So those are things which you will be.
Yes.
Okay, final question for each one of you and then we finish the
I
course.
think the UV protective glasses should be for your Smile Extra patients because we've had patients Smile Extra works
Yes,
wonderfully
yes.
well,
Yes.
but
Cross-linking, all cross-linking.
the cross-linking, so they may develop UV pro.
Agree.
yeah.
So we are finishing off by one last question and we'll finish it in one line. What percentage of your practice, and I'm going to ask each one of you, is now PRK, lenticule and LASIK?
Okay, so the proportions have changed in past 6 months. So if you ask me last year, it was 40% LASIK, 40% trans PRKs, but now it would be 30% LASIK, 30% Smile or extras combination, maybe 20 to 25% trans PRKs and then Fakicals. Because what we have seen is, again, sir, your experience is saying the same. The Smile extras work very well. And if you want to reduce the chances of, don't want to have haze, pain and everything after surgery, then I think Smile Extra is one option what we give. If patients are traveling abroad or if patients are into occupation where they cannot follow up, we do a lot of Smile Extra. So that's why the dynamics have changed.
CFS?
50 to 60% lenticule, KLX, 20% PRK and just 10% flaps.
Right.
Flaps are only for the eye.
And Kumar's place, Shivani?
Flaps, LASIK followed, and now we've started increasing lenticule. So LASIK and lenticule mostly, less of PRK.
And Kamal's place?
So till maybe 8 months ago, we were around 20% surface, and now it's less than 3-4% because me being the boss, I'm not doing it, so my other surgeons are also.
What about
stopped doing it.
lenticule and LASIK?
Lenticule? We just discussed with you. We're going
Oh,
into
yeah,
the
yeah,
lenticule.
absolutely.
We're picking up the machines now.
And Dr. Chitra, your place has had lenticule
In
for a
our
long time.
patients,
so-
75% is lenticule. High cylinders, though Smile is doing very well, we do contour LASIK. And for corneal thickness, which is less than 490, we do PRK. Or we do PRK if the patient cannot afford other procedures. Even if it is 500 plus, we would do PRK for those people who offer some job training and all that.
Sure. Thank you so much,
Thank you.
everybody, and thank you all the faculty. We'll have a quick